All right, welcome back. It's been about a month. I'm Dr. Patterson. For those of you that may not have never tuned in before, for those of you who remember me, I hope you're glad to see me. But tonight we're going to be talking about persistent postural perceptual dizziness, or PPPD. I'm going to say PPPD a lot. You're probably not going to hear me say persistent postural perceptual dizziness because I couldn't even get it right 2 times in a row. So, all right. A little bit about myself. We've talked about it before. I'm a licensed chiropractor, board certified in chiropractic neurology, fellowship of mild traumatic brain injury, and then I've been with the team since 2022, but I interned back in 2014, so it's good to be back. Georgia Chiropractic Neurology Center. We are chiropractors specializing in multidisciplinary neurorehabilitation. So we have those board certifications, which means that we've spent a ton of time learning how to perform neurorehab procedures, meaning that we work with the brain's ability to change and adapt, what's known as neuroplasticity. So we do sensory and movement-based exercises with our patients to help them improve in their symptoms. As I said, we harness the brain's ability to change and adapt, right? Neuroplasticity. So our topics for this talk: what is PPPD? How is PPPD typically diagnosed? I missed a P there. How is PPPD typically treated? I missed another P. And how does GCNC bring new hope? And we'll talk a little bit about some patient stories as well, and then we'll have some time for questions. So triple PD is a type of chronic vestibular disorder, and it was defined in 2017. So there's several different disorders, vestibular disorders. So vestibular, we're talking about the vestibular system or the inner ear. So it's typically thought of as having an issue with dizziness or balance when we have inner ear processing challenges. But as we're going to get into tonight, the inner ear, while a big part of it is inner ear processing as far as where is our head in gravity relative to space, it takes into account processing of other sensory systems as well. But these different vestibular disorders or inner ear processing disorders that lead to dizziness, disorientation, and a lot of other symptoms for people, there were several different types. They were all of kind of a visual type, all right, that led to non-spinning vertigo, typically, or non-spinning dizziness. When we're talking about vertigo, usually there's a rotational element to it. I feel like I'm spinning this way or I'm spinning that way. This is a different type of dizziness. So, however, it is the second most commonly diagnosed disorder in dizziness clinics. So that's pretty darn common. Now, I talked about how the diagnosis was first proposed and came about in 2017, but there were these other diagnoses that were all grouped together that kind of described it as well. And that's probably part of the reason why it's one of the more common disorders. But one of the other things that we need to take into consideration is that it's what's considered a functional vestibular disorder, meaning that it's not structural, but it's also not a psychiatric disorder. So what the heck does that mean? So some people might have a structural issue with their inner ear processing or their vestibular system. One of the examples of that is sometimes people, unfortunately, will get a tumor on their acoustic, what's known as an acoustic neuroma, which is a growth on the nerve that comes from the inner ear. Okay, and that can cause dizziness or vertigo. That's a structural issue. That's going to show up on MRI. Okay? Sometimes people will get what's known as vestibular neuritis, where that nerve gets inflamed, and then that can lead to dizziness or vertigo. Okay, and that's would be considered more of a structural issue. There's also people that have psychiatric challenges where they also have some dizziness with it. Now, functional vestibular disorder kind of falls in between, which makes it complicated. When we were looking at different functional disorders, there's different ways to look at it. And I want to backtrack a little bit. A lot of this presentation has come through a few different research articles regarding PPPD. One of them in particular has to do with that origination of the diagnosis from 2017 from the Brainy Society, which is a society that is long-standing and was named after one of the pioneers in understanding inner ear or vestibular function. But anyway, this society links up researchers and clinicians so that we can help the world that is dealing with these dizziness issues. But anyway, I bring up that article because that article brings up an important point, that this is considered a functional vestibular disorder. It's not structural, it's not psychiatric. At one point, a functional disorder, or what could be known in this case as a functional vestibular disorder, was thought to be more or less purely psychiatric. That's kind of in the middle period. At the beginning, when people are first looking at functional disorders, they realized that there was no specific tests that could be done that could be traced back to these disorders. And it's like, oh, all right, so we know that these tests came up, so this is most likely what's going on with the physiology. They looked at a functional disorder as there's something going wrong with the function, but we don't know what's going wrong structurally, right? It's a hardware issue versus a software issue. Then it turned into, well, we don't really know what's going wrong structurally, so it must be a psychiatric issue, right? So it's just a psychiatric issue. And then it's been put under that category for many years, but one of the things that I liked about the Brainy article is going back and saying, hey, maybe we need to understand that maybe we can't figure out exactly what's going on structurally with this disorder, but it's also not just a psychiatric issue. You know, not to belittle psychiatric issues, you know, they're serious things, but this isn't a psychiatric issue. We can't figure out what's going on with it exactly structurally, but something's going wrong in the organ system that's involved with these functional disorders, and these people are having real symptoms. And even if it was psychiatric, there can be real symptoms associated with it, but this is something going wrong with how something in the body works for someone. We just don't fully understand the organic basis of it. And that's something that needs to be respected, because oftentimes people in the community that have been diagnosed with a functional disorder feel like they're often ignored because people try and say, oh, it's a psychiatric disorder, so it's all in your head. So if you can just get over it, you'll be fine. And it's not that simple. And anyone that's dealing with these disorders can tell you that's definitely the case, that it's not that simple. Not that psychiatric disorders themselves can be simple, but there's some pejorative aspects when we dismiss the fact that this is a unique instance, right? Where function has gone wrong, we just don't fully understand where the structure is involved. And I apologize if I spent a long time on that, but it's an important thing to understand. Now, it's a disorder that's more common in women, 46 to 55 years old. Not to say that this disorder couldn't happen in men, but it's more common in women. And the average length of the condition is 4.5 years. So that's a long time to be dealing with this issue. So, and another challenge that I highlighted here is that it doesn't have to exist in isolation. You can have triple PD and you could have another type of vestibular disorder. You could have triple PD and several other things. You don't just have to have triple PD. And I'm going to talk a little bit later about some patients that I've worked with where, yeah, they likely have triple PD, okay, but they also have some other vestibular challenges that is leading to other types of dizziness issues, disorientation issues, brain fog. We're going to get into what PPD is as far as how it's experienced by people, because I keep talking about dizziness, but it's more than just dizziness as well. And we need to understand that. So how is triple PD typically diagnosed? So one of the challenges is there are no findings on physical examination, laboratory testing, or diagnostic imaging that are pathognomonic for PPPD. And that's why it's considered to be a functional disorder, because it's not like there's a blood test that we could run, or we could just run an MRI and then we're like, it's PPPD, right? It's triple PD. It's not that simple per se. So what it winds up being is an in-depth look at a person's health history, right? It's a primary factor in diagnosing triple PD. As we're going to get into this, though, interestingly enough, these research articles that propose these diagnostic criteria also talk about areas of the brain that are involved with triple PD. So we're going to talk about what we do in our clinic to systematically test different areas of the brain, and that's going to give us more insight, right? So it's not necessarily just all about the history, but to officially give someone this diagnosis, the history is a big component, okay? So as I said, the Brainy Society originally proposed the diagnosis in 2017, all right? And they require 5 criteria to diagnose someone with triple PD. One thing to note as well is there's these things that are known as diagnoses of exclusion. Essentially, you know, there's some basic criteria that need to be met for a diagnosis, but also on the same hand, if we know that you're dealing with dizziness issues and it's kind of a postural thing where you change positions and you get dizziness and disorientation and nausea and all these other symptoms that we're going to talk about in a bit, and we can't really figure out what else it is, then, well, you probably got triple PD. Well, the argument that the Brainy Society is trying to make is like, you can't just say, well, we can't figure out what it is, so it must be triple PD. Although, to be honest with you, in a clinical setting, that's often what is done, although it's arguably inappropriate. So the 5 criteria to diagnose triple PD. Number 1, one or more symptoms of dizziness, unsteadiness, or non-spinning vertigo, right? And these kind of sound similar, like dizziness versus unsteadiness versus non-spinning vertigo, but they can be experienced as kind of different things. And one of the challenges with this diagnosis is that it can be very difficult for the person to describe exactly what they're feeling, right? It's not like I'm rotating to the right, like it is with some other vestibular disorders, where it's pretty easy to describe it. Sometimes people have a tough time trying to come up with the words to describe the sensations that they're feeling. So the symptoms must be present on most days for greater than 3 months. So they're trying to establish that this is a chronic issue because triple PD is considered to be a chronic issue. So it's got to be going on for longer than 3 months. Doesn't mean that you shouldn't seek help earlier if it's less than 3 months, but that's what they're saying for the diagnosis. The symptoms last for prolonged periods of time, but don't necessarily have to be present continuously throughout the day. Meaning that sometimes you got the symptoms, sometimes you don't. Sometimes they're really intense, sometimes they're not. Sometimes you got this symptom, sometimes you got this other one. But overall, it should be fairly persistent, even if it's not necessarily there all the time. And like I said, they can increase and decrease in severity. So persistent symptoms occur without specific provocation, but are exacerbated by 3 factors. This is criteria number 2. So without specific provocation basically means like there may not be a specific circumstance where it's like, yeah, every time I stand up and I turn to the right, all these symptoms come on. It may not be that simple, but there's 3 factors that seem to be a part of this. And it's upright posture, right? Meaning you're standing upright or in a more upright position. Active or passive motion without regard to direction or position, meaning like you could move this way or you can move this way, and you could move or somebody else could move you, or you could be in a car and someone moves the car. And it's, once again, I said, it's not like every time you stand up and turn to the right. It could be like, yeah, sometimes I go to the left, sometimes I go to the right. It's difficult to predict when it's going to hit me. And exposure to moving visual stimuli or complex visual patterns, right? That can be an exacerbating factor, where you could be, say you're at the Marietta Square, one of our local lovely areas where there's trains that go by, and you see a train going by. That could be very visually disturbing. Or just watching traffic when you're in the car can be very visually disturbing. Or even just me waving my hands around. That can be pretty visually disturbing for people. So the disorder also needs to be precipitated by conditions that cause, meaning that there was something else that then led to triple PD. So it could be vertigo, it could be unsteadiness, it could be dizziness, right? It could be problems with balance, including acute, episodic, or chronic vestibular syndrome. So other types of inner ear processing or vestibular issues, right? Other neurological and medical illnesses. you could get what I described before, what is known as vestibular neuritis, where like you get a virus and then it affects your inner ear processing with that nerve, and then that starts to resolve, but then your software with how your brain interprets things gets scrambled, and then you wind up with triple PD. There's also psychological distress. There's arguments that, a traumatic psychological event could bring on triple PD and lead to it, even absent something else like that vestibular neuritis or some other dizziness disorder that you had previously. And that's one of the complicating factors where if it was a traumatic psychological event, right, then that could have led to changes in how you interpret the world, but it's not going to be something that's really going to show up on imaging or a lab test. So criteria number 4, symptoms cause significant distress or functional impairment. All right, so it's got to be rough. That's essentially what that's saying. Like it's got to be a pretty rough syndrome. And then symptoms are not accounted for by another disease or disorder, so there isn't something else that better describes what you got. And sometimes I think a little bit of liberty's taken with that. See if my pointer works, sort of. But I think sometimes a little liberty is taken with criteria number 5, where it's like, well, we don't know what else it is, so it must be this, right? I would argue you should really need to be able to meet some of those other criteria, those other 4 criteria, right, to be able to say that triple PD is what we're dealing with. So let's look at the symptoms one more time, right? Well, you need one or more symptoms of dizziness, unsteadiness, and non-spinning vertigo. So what exactly does that mean? What could that feel like? What could that be described as? So dizziness is a non-motion symptom. Could be cloudiness, fuzziness, fullness, right? Some people talk about fullness in their ears, or they just feel like their head is full. They could feel heavy, like a heaviness in their head, or just heaviness in general, or lightheaded in the head. Non-motion meaning it's like not rocking. Okay, or a feeling that their spatial orientation is not sharp and their vision isn't clear. So it's like, I really feel like I don't know where I'm at in space, and things are my vision's just cloudy, or things just don't look clear, right? Let's look at unsteadiness. What could that be described as, or what could that be felt as? Sensations of instability or wobbling when upright. You just don't feel stable on your feet. It could be like, I tend to veer from side to side, or it could be like, when I'm walking, sometimes I just tend to go to the left, right? Although they argue there's not a directional preponderance to it, but it may be like one day I'm walking to the left, one day I'm walking to the right. It doesn't necessarily mean that you have to go back and forth and back and forth. And then let's look at number 3, non-spinning vertigo, which is feelings of swaying, rocking, bouncing, bobbing, right? So you can feel like you're bobbing up and down. A lot of patients will describe, I'm walking, and it really feels like I'm bobbing up and down. Or they could just be standing and it feels like they're bobbing up and down. So it could also feel like motion in their heads involving their entire heads or bodies occurring in the environment. And then it could also, it's apparently less typical, but it could be like tilting or sliding sensations, where you feel like you're gradually tilting to one side or just sliding somewhere. But it's just a strange type of movement. It can be different for different people. You could have one from each of those categories. You could have one from one of those categories. Usually it's a combination of things, but it can be different for different people, which makes this a tough diagnosis to make. So let's talk about what could trigger these symptoms. What's known as a visual conflict. That means it just doesn't quite look right. You may see something that's moving, and you're still, but then all of a sudden you feel like you're moving, right? Or you may see like 2 cars driving in different directions, right, across the intersection, and that's causing a visual conflict. Head motions can trigger it. So just turning your head, whether you turn it this way or you turn your whole body in the chair, or somebody turns you in the chair, or just the car turns. Stress can be a factor. Sleep, or more likely lack of sleep. Upright postures, standing or walking, right? That's in the name of triple PD. Environments with complex or moving visual stimuli, such as cinemas. or highly visual places like supermarkets, just staring at traffic. A lot of our patients that have triple PD, like they don't feel comfortable going shopping. Because when you're walking down the aisles in the grocery store, we kind of take it for granted. Like we may be looking for that one bag of chips, but there's all these patterns and colors, right? Going down the aisle. And sometimes there's a bunch of blue and then there's some red. And there's just all these different visual items. And as you are walking down the aisle, that can be really overwhelming for people. Then there's like the lights above, and sounds can even get involved as well, right? It could be just a sensory rich environment. The supermarket can be a really tough place for somebody that has triple PD, or if they have some other types of sensory processing issues, which we might get into in a little bit as well. Right? Sitting in a crowded restaurant can be really tough. That's a pretty sensory rich environment with so many different sensations going on, so much conversation, so much movement, right? That it can just be overwhelming. So what do we do about it? So how is it typically treated? So it's typically treated with medication. Typically we're talking about SSRIs. So it's a psychiatric medication. It can help with anxiety, right? Because we know that stress and anxiety can be a component in this. And even like a psychological trauma could lead to triple PD. So that's a piece of it, or it can be a piece of it. Psychotherapy, typically cognitive behavioral therapy, okay, in particular. It was interesting, you know, what a quote from one of the articles that I read talked about how the preferred kind of psychotherapy is short cognitive behavioral therapy. And it talks about this therapy enables the patient to express the distressing circumstances and select the appropriate response, right? So that kind of really simplifies things. I wish it was that simple to a certain extent and be like, I have issues with this situation and then I should react this way. And it's important to contextualize like what is a dangerous part of your world and which is a safe place, right? But it can feel like a very dangerous part of your world if you feel really disoriented just walking through the grocery store. But cognitive behavioral therapy can be a very powerful tool, right? And that's just a simplified way of describing it. Now let's talk about vestibular rehabilitation, which is a little bit closer to home for what we do here. There was also an interesting quote that came from one of the research articles as well, talking about typically with vestibular rehabilitation, what we're looking at is we're trying to figure out dysfunction in that inner ear processing or vestibular processing, and sometimes some other systems as well. And we're going to get into those other systems when we talk about how we do vestibular rehab here at Georgia Chiropractic Neurology Center. But sometimes vestibular rehab is done basically to help you adapt to the sensation, meaning like let's keep doing this and exposing you to this until it doesn't really bother you as much, right? Almost like exposure therapy. And sometimes people will do certain levels of exposure therapy, even from like a psychiatric treatment standpoint, where they want to expose you to more and more sensory rich environments and just train your system to not react poorly to it. But this talks about how the standard procedure of adaptation, which would be kind of that exposure therapy I talked about, and substitution, meaning you train your system to rely on plan B, because maybe plan A, the inner ear processing, isn't working well. But instead of doing that, we want to focus on to accurately diagnose problematic movements and showing the patient that their anxiety of performing these movements is unwarranted. I think that's a little harsh, right? Because this is basically saying, let's figure out what jacks them up, and then let's just show them that it's not appropriate for you to feel this way. And I would say that's a little bit harsh. And it's, you know, I'm not trying to come down on the people that write these articles, because they're obviously giving us very valuable information that helps us treat our patients every day. But we need to be very careful in the language that we use. And sometimes people take this a little bit too literal, whether it be clinicians or other people that are friends or family of the person dealing with this disorder. It's not, as I said before, it's not as simple as just being like, hey, this is not too bad of an environment. You should be able to tolerate this, right? Let's take you through this environment. Let's take you through this store. And it really shouldn't be that bad for you, because it's usually not that simple. You can't really talk the person through the situation, right? And sometimes this language makes it sound like that. And I would argue that this kind of continues to persist that thought process that this is purely a psychological disorder. It is not. So triple PD in the brain. So now I feel like we're getting to some cool stuff, right? Not that the other stuff wasn't cool, but this is where we jump in. So changes in visual and vestibular information, right? So with the brain, its processing of visual input and inner ear processing is skewed. So if I turn to the right, my eyes should see that I turn to the right, and my ear should tell me I'm turning to the right. And if my ear is telling me I'm turning to the left, and my eyes are telling me I'm turning to the right, your brain doesn't know who to believe, and then you could feel dizzy and disoriented. Do you feel like that could be confusing? Say if, you put on green shoes and everyone around you is telling you that they're red, and then you start to question your own beliefs of what is the color green, right? So your brain doesn't know who to believe because it's getting visual input saying one thing and inner ear input saying another. So visual, spatial, emotional, and vestibular navigational brain networks, which combined visual, vestibular, and emotional responses to assist spatial mobility, have reduced functional connectivity in triple PD patients. What the heck does that mean? So your emotional systems and your inner ear processing, arguably all of your sensory processing, but this in particular is talking about what you see visually and what you sense from the movement that you pick up with your inner ear. This is also tied to your emotions. All of our sensations, right? That's why you could walk into someone's house and they could be baking, say, like chocolate chip cookies. And then you smell the cookies, and your grandmother always made chocolate chip cookies. And you smell that and you think of your grandmother, and then you think of your grandmother and you're happy. And then you get one of those cookies and you just feel it in your hands and you're thinking more and more about your grandmother. This sensory experience that you're having is tied to memories and emotions. And our brain, when we experience our world, it's taking in sensations. Even in this somewhat boring room that I'm in right now, there's not too much going on. Just boring meaning that visually there's not a ton going on, right? But my brain still needs to take in everything going on in here and figure out, is this a threat? Am I in a safe place? Do I need to move towards something? Do I need to move away from something? Or am I pretty cool right here? And then it's going to reference that sensory experience against your memories. Like, I've been in this room before. Nothing bad has ever happened in here. And then it's going to reference it against your emotions. I'm already in a pretty good mood, right? There's not a threat in here, so I'm feeling pretty good. Your emotional state can affect your sensory processing. Your sensory processing can affect your emotional state. Your memories can affect any one of those three categories. So all of this is tied together, right? And it's wired together in the brain. So we need to respect that and understand that, and that's why we could have some psychological overlay between anxiety and feeling dizzy. And I don't think it's a far stretch to be like, hey, if you're constantly feeling dizzy and feeling like garbage, like, it would be weird if you didn't feel anxious or depressed or angry at times, right? Because you just don't feel good. So in triple PD, patients have increased visual cortex activity, which is linked to how dizzy they feel. So there's some arguments as well that since your inner ear processing isn't quite right, we tend to rely on things heavily visually when you have triple PD, meaning we're really visually dependent. And because maybe our inner ear processing, how that's being interpreted, it's not fully accurate, so then we become really dependent on our vision. What does that mean? If we get in a dark room, we can get really disoriented. If we get in a really visually busy environment though too, since our vision is already heightened as far as its sensitivity, then we can get overwhelmed. So you're kind of relying on your vision because it's more accurate than your inner ear processing, but you could also ramp up that system, and then that system's not working well either. And then you have problems with both. So you could also look at PPD and reflect on changes in spontaneous functional activity of the cuneate lobe and anterior cuneate lobe that may lead to abnormal integration of visual and vestibular information. Once again, visual and vestibular information. Vision and inner ear processing, right? How that's integrated is poorly processed. And we've got names of areas in the brain. This is a brain issue, right? So we may not be able to see it on MRI, but it's a functional issue, meaning it's a software issue. It's not a hardware issue. The hardware is pretty intact. It's just the way your brain processes things is inappropriate. So it also talks about how patients with triple PD experience reduced blood flow to cortical regions with altered anatomical and functional connections. Once again, visual and vestibular network. So this visual and vestibular system, really important. So how do we figure that out? How do we figure out how well the visual system's working well and how well the inner ear processing is working well? And we're going to talk about that, and we're going to talk about another area of the brain that's called, or another, not area of the brain, but another type of sensory processing, which is called proprioceptive. So I think it's pretty straightforward for the most part. Like, we all fairly understand how vision works, right? Something happens, we see it. But not only what you see, but how stable are your cameras or your eyes when capturing a video of the world, right? So what do we see, but also how stable are your eyes is going to be a part of your visual processing. Okay? And then are your cameras pointing at the same thing? Because sometimes we get double vision because one of our cameras, I'm talking about our eyes. One eye might be pointed at one thing and the other eye might be pointed at another. And if that's a new eye position for you, it's not like you grew up this way and your brain learned how to adapt to it. If one eye goes in, you're probably going to see double. Okay? But anyway, there's visual processing. Then there's what's known as proprioception, which is joint and muscle feedback. We haven't talked about this one yet, but proprioception is joint and muscle feedback. So it could be the joints and muscles in your neck. It could be the joints and muscles in your feet and ankles, right? If that sensory processing gets messed up, that could be one more liar in the system, and that could be one more thing that's throwing you off. And some of the research articles also talked about how posture changes with triple PD and how posture can be an effect of it, right? And posture is in the name of triple PD, right? And our proprioception, or our joint and muscle feedback to our brain, as far as where we are in the world, is going to be a part of that. And then, as I said, vestibular inner ear processing, we talked about that a little bit. That's where is our head in gravity. So how do we test these systems? So we look at balance is one of the ways that we can test these systems. There's multiple ways, but let's talk about how we test balance in the clinic. So how do we test the visual system? We're going to put you on the floor like you see me in this picture, and like I'm standing here right now, and your eyes are going to be open. Excuse me. You're going to be able to use all three of these systems to have a good balance. And I don't know if you caught it in the picture before, but that was our fancy vestibular testing device. It's so there's plates that you stand on that you can see me standing on in the picture, and then it puts you in a VR environment. And then we get data, we get readings, we get graphs, we get numbers, and I'll show you one of the graphs as far as how good your balance is, right? And when we test these different systems, how much does your balance change? If it changes too much, then we got a processing issue. So when I'm standing upright with good posture and trying to stand as still as I can with my eyes open and I can see the world, I'm mainly relying on vision to give me good balance. Joint and muscle or proprioceptive feedback and inner ear feedback is a factor as well. But 70% of what creates my good balance, there's research to back this, is from your vision. So it's mostly vision. Not all, but mostly vision that's giving me good balance here. So what happens then when I'm standing on a flat surface and I close my eyes? I can't use vision anymore. The next most dominant system in that scenario is going to be joint and muscle input, in particular from your feet and ankles, right? And we may see that people sway a little bit more, and we may get more data that tells us that. But if there's too big of a change, then we know that that joint and muscle feedback is inappropriate. And it's not to say that vestibular doesn't have a factor in that, right? Because I'm still getting inner ear input, but it's mostly that joint and muscle input. So we've talked about how we can test visual. We talked how we can test proprioceptive to see where the deficits are, right? What is the problem area? Or maybe it's a combination. For vestibular or inner ear processing, you close your eyes and you're on a foam pad, okay? With the foam pad, it messes up your joint and muscle feedback from your feet and ankles. So your brain's like, all right, we can't rely on the feet and ankles. So how are we going to stabilize ourselves? Well, if your eyes are open, your visual feedback could help. But if your eyes are closed, then we really got to rely on this inner ear feedback, right? And yeah, if you're on a foam pad and your eyes are closed, like your balance is not going to be as good as me just standing here like this with my eyes open, okay? But it's how much of a change do we see? So if we see too big of a change, then we know that your inner ear processing is probably off. And then we need to run other inner ear processing or vestibular testing to really pinpoint where your vestibular processing deficit is coming from. And then we do sensory and movement-based exercises to rehab that system, get your vestibular processing as accurate as we can. You're probably going to be more stable in your balance. You're going to be more stable in your world. Your inner ear maybe is lying to you less. And then you're going to feel better in the world, and you're not going to feel as dizzy. So when we look at the data, there's a lot of data that we get, but this is kind of a simplified graph version that we get. We can see different scenarios that we test, and then we want people to be in the blue zone. We don't want them to be in the red zone that you can see here. And the black line is the average person in your age range. What kind of balance are they getting? And the higher we are on the graph, the more stable you are, right? So if you're in the orange area, you're below the black line, so you're below average. So maybe that test was too tough for you. And with this person, the toughest tests for them, where they got 2 orange bars, right? They weren't hitting that black bar. Where they got the 2 orange bars was with their eyes open on the flat surface and their eyes open on the squishy surface. So they were less stable, sorry, let's go back, in their visual processing. So this gave us like an overall view of all those systems. Somatesthesia, that's essentially proprioception, visual, and then vestibular, like we talked about. So this person is less stable statistically, maybe not overall, but they're doing pretty good in those other positions compared to the normative data, but they're less stable with their eyes open. That seems a little weird. You would think that they would be more stable with their eyes open, right? That would just kind of make sense. But for them, too much visual input. So we need to down-regulate their visual system and make it more accurate. That's the big takeaway. So what do we do with vestibular rehab? Let's talk about it. So as opposed to finding your triggers and then trying to expose you to them and show you that, you know, that these should not make you feel this way, or maybe exposing them to them over and over and over again until you can tolerate it. A different way to do it, the way we like to do it, is we gradually increase the complexity of your movement, right? Or things visually. So what does that look like? Let's talk about one of the exercises that we use with people with PPPD and other types of vestibular issues, right? Or vestibular processing issues. Because we see people with PPPD, we see people with various types of dizziness issues and disorientation, but we also see people with vestibular processing issues that have digestive issues, have what's called dysautonomia, kids with neurodevelopmental disorders such as autism and sensory processing issues, people that have had concussions, people that have anxiety disorders, that their primary complaint is anxiety. You could have poor vestibular processing, and vestibular rehab to help that vestibular processing could help any one of these people in these different categories and more, right? So this is very important to how we function and how we take input from our world and make sure that we know where we are in our world so that we don't get these symptoms in any of those categories. All right, so can I have somebody come up here? Can I have either Dr. Hose or Dr. Wright? Whoever wants to volunteer. Okay, Dr. Wright. Cool. So we're going to talk about gaze stability exercises. So can we turn the camera to the front now? All right, so we're going to rearrange the camera a little bit. Dr. Hose is helping us out. And I just want to, I meant to put it at the beginning of my presentation, but Dr. Hose was very helpful in me generating my presentation. It's not been published yet, but she did a really great blog post that will be on our website, and I would highly suggest reading that because it goes a little bit more in depth in some of the areas that I didn't cover quite as well. But it also is a little bit more succinct than, my jabbering here. So I would definitely recommend that you find that on our website. However, I'm not sure when that's going to be available. It probably won't be available for another couple of weeks, I would think at least. But she did a great job writing a great blog post. And it was actually helpful in me generating my, my presentation tonight. We traded some ideas. All right. So I don't necessarily want to block people's views, but can we still see that pretty well? Yeah. So the reason I have this is there's a little red dot on it, and I need Dr. Wright to have a target that he can look at. So there's different ways that we can have him interact with his target. And my overall goal is to get his head moving so that his head, his inner ear processing, right, has to process this movement. I have him looking at a stationary dot. It can be helpful to have something stationary to look at. It's less disorienting for him, right? So he's looking at a dot, and I need to move his head back and forth. For some people, this is a great exercise. They're called gaze stability exercises. Some people, when we also track people's eye movements, that's another diagnostic that we run, we'll see that their eyes just don't stay on a target. This can help stabilize eyes on a target, because if we have eyes that are constantly moving around the world, even though we're not aware of it, and we're not trying to look at different things, but we may have just these subtle little movements, it can lead to visual disorientation, even if we're not really even if we're not fully aware of it, right, or consciously aware of it. We'll see sometimes too where we get these little twitching eye movements and people feel really anxious. So this is one of the ways that we can stabilize that. And we can work on inner ear processing, but it's also a visual exercise because he's looking at the dot. And guess what? It's a proprioceptive exercise because we're activating the joints and muscles in his neck. And we could get bigger activation from those joints and muscles too if he does it. Sometimes we'll have them do it, the patient. So now he's doing it. That's a little bit different from me doing it. I had a patient at one point where one of her biggest disorientations was when she'd turn her head. I was checking her balance, and then I said, hey, let's check your balance when you turn your head. And she got way worse, and she felt really nauseous, right? So that wasn't good. So she also had some of these shifting eye movements. I knew that if I turned her head and did her gaze stability exercises this way, that it was just going to make her feel nauseous. Guess what? I did one. I said, hey, let's do one. And I went, one. How does that feel? And I knew it didn't feel good because she went from, right? And then she just, did not feel good. So that wasn't good. So what do we need to do? We need to get these systems to be better in agreement. But I don't want 3 different systems working together. I want to isolate this more. So what did I do for her? Can you look at the target? I put her in this chair, and I rotated her back and forth. Dr. Wright's eyes are still looking at the target, okay? And his inner ear is still getting exercised. But now his neck is out of the equation. And if he's getting poor input from his neck, then this is going to be easier for him. This was easier for her. So what did I need to do? I needed to focus on getting her inner ear processing better, her visual processing get better. I needed these two systems to be in agreement, but I wanted to leave the third system out of the equation because it seemed to be a major factor, and this was the big liar. I would argue they were all lying a little bit and telling her, hey, instead, I did this. She probably felt like it was like that. That's how her system perceived her neck turning. It was very violent and disturbing for her, even though I had her do this on her own, right? And she just felt, oh. So we rehabbed just her eyes and her inner ear processing. Then we did some manual therapy on her neck, got her joints moving better, loosened up her musculature, and then we got her to the point where we do it passively. Then I was like, hey, let's do it actively. That was too much. So then we gradually had to, I would do some passive and get her system working pretty well. And then I'd be like, all right, just give me one active. And then she could do one active where she was doing it. So we just had to build it up, right? So I would argue that we need to gradually increase movement complexity or visual complexity. And that's what we did with this. Another way to build up visual complexity is I just have a red dot on here. Another way I could do this is to put more dots on the wall. That's a little bit more complex. Sorry, I'm walking around the room grabbing stuff. Another way we can make it more complex is to use a striped background. For some people, they look at this and they just get a really bad feeling in their stomach just from looking at this, even though it seems fairly innocuous. But then they're turning their head looking at this. This is a more complex background. Then I might bring up an iPad where these stripes are moving, but the dot's stationary. And then they can tolerate that. Then I'm ready to take them outside and maybe do it outside. Have them look at a tree off in the distance while cars are driving by. Then I just take them outside when it's at a busy intersection and there's a bunch of cars going by. And they're like, hey, this is cool. Like, I don't really feel much. Like, this doesn't really bother me. That's really awesome. But going from sitting in the chair to let's just go out there and see what happens. And let's just keep doing that until you feel better. It's probably not going to be a happy road. And believe it or not, doing these baby steps oftentimes works faster. So does it kind of make sense from how we could, up the complexity from going to a single dot to a striped background to something outside? Sometimes we're doing just the eyes and the inner ear. And then sometimes we're doing the neck as well. And then sometimes we get really crazy. And can you look at the dot? Mm-hmm. And we just do the eyes and the neck, right? And now the inner ear isn't really getting much processing, because even though I'm a little sloppy right now, and normally I'd take a little bit more care with this, his head isn't moving that much. So that's another way we could rehab the neck and the eyes. Okay. Now, I'm not saying if you have triple PD, you should try the things that I'm showing you, and I should have told you that before I started showing you things. But I would not necessarily recommend that we do these things at home. Is that in my way? Is that what you're trying to tell me? Okay. So don't stand in front of the thing in front of my face. But yeah, don't necessarily try these things at home, okay? Because different people need different things. Some people would be overloaded by just doing this simple exercise of turning their head or turning in the chair. So I don't recommend it. It's all based on individual patients' individual needs. I'm just giving you an idea of what therapy looks like here. So there's also visual movement eye exercises, and we want to gradually increase the visual complexity, right? Just like we gradually increase the movement complexity with vestibular rehab. So even though that was arguably kind of an eye movement exercise too, because his eyes were looking at a stationary target, but they were moving at his head, this is another visual exercise we could do. So can you look at my thumb? And then it seems pretty simple, But Dr. Wright is just tracking the movement of my thumb. And that's kind of a basic way to start out. Some people can't handle that initially. So then that's when we might go back to that gaze stability exercise, where their eyes are technically moving, but it's on a stationary target. And that's step 1. Then this is step 2. Can you see that? Yeah. This might be step 3. Look at this one. Or this could be step 3. Look at the front one. There's multiple things going on here. Right? Look at the front one. Then we could switch to look at the back one. And we go in multiple planes. That could be really tough for somebody because that's a pretty busy visual environment for some people. So we'd gradually build them up with just one thumb. Right? Maybe it's the dot, then it's one thumb, then it's two thumbs going in the same direction, then it's thumbs going in opposite directions, right? And we create a more and more rich visual environment. Does that make sense? Now, how do we train proprioception of that joint and muscle information? I already told you one way. We could have Dr. Wright look at the target, and then I turn his body, and his vision is like, hey, we're remaining still. But my neck position is changing, right? But just because my neck position is changing doesn't mean that my vision isn't still, okay? Another way we could do it is with what's called point localization. So I might take my finger, and then Dr. Wright's eyes are closed, and I touch a spot, and then he has to touch the same spot. And how accurate is he? He's pretty accurate there. Sometimes I touch here on a patient, and then they wind up touching over here. They don't really know where that arm is in space. So then we either do repetition, where each time they get a little bit more accurate until they can hit it directly on the target, or sometimes it's, hey, open up your eyes. And look where I'm touching. So they can use their vision to get a better idea where there's touch sensations happening. Or maybe I do a little bit of movement with some joints in this limb. And then it helps with the brain's awareness of where this limb is in space. Or I might do a little bit of electrical stimulation, say along his median nerve, sending some signals up to his brain, getting better awareness of this limb is. And then I go back and I check that area again. And then lo and behold, he's more accurate. So he better knows where the joints and muscles are in space. And we can do that with his leg or his ankle, we can do his foot, we can do it with his neck, right? So there's different ways that we can ground people in their proprioception or ground them in their world where they know where their joints and muscles are at positionally. Because for that patient that I talked about, she would turn her head to one side or the other and she would get really nauseous, which is not a happy day for her. So I've worked with several patients over the years that arguably have triple PD. Some of them had the diagnosis, some of them didn't. All of them had visual difficulties where oftentimes their visual system was ramped up. Some of them not so much, but they had some kind of visual or vestibular mismatch where one system was telling them one thing and another was telling them another thing, or both maybe were in agreement and it's just hey, they were moving this much, but their system thought they were moving way more than they actually were. It was just really ramped up. So I gave the example of the woman that turned her head, right? And just turning her head would make her nauseous. And she kind of realized that, so when I first saw her, she would walk around like this. Maybe not with her hands clenched, but she was not moving her head and neck at all. So we eventually got it to where, yeah, she can move her head and her neck, and she's working part-time now at work, which is a big accomplishment for her. But yeah, we need to get it now to where she can work in an office environment and she can look at her colleagues and it's not as disorienting. What we're finding with some of these cases, for her, I got her proprioception better, and then now we need to work on more visual stuff and down-regulate that visual system. So we need to peel back the layers. I've got another patient that I've been working with where she arguably has triple PD, although she never really fully got the formal diagnosis, but she'd get visual disorientation when she'd walk up to a colleague in the office and she would have a conversation with them and they were about 4 feet from her. Every once in a while, she'd just be like, whoa. And she'd feel like she was being pushed, or she'd feel like she was swaying. So we were making progress with that. And then all of a sudden, she started having a different type of vertigo. So she's an example of where arguably she has triple PD, but then something else happened and she had a different type of vertigo. I would argue she had a crystal in her inner ear that was stirring up her inner ear processing in one inner ear. And then we did some rotational maneuvers with her and it cleared that little crystal out that belongs at another place in her inner ear and just tumbled in the wrong area. And that got her system back on track. She's actually got a little bit less now of her triple PD symptoms. But she arguably had both, not just triple PD and not just the crystal in the inner ear thing. She had both. I'm not sure why, this crystal went up from the one area to the other for her. It can be for various reasons, but she had something else pop up. So that's just an example of triple PD can be on its own, or you can have multiple things. And sometimes it's from the start, or in her case, she had triple PD for a while, and then this crystal thing happened. And then now we're just focusing on the triple PD again. And that, honestly, she might have had a crystal a long time ago, and maybe that's what triggered it in the first place. But I'm glad we were working together on a regular basis to where this new problem happened, and then we worked on that for a couple weeks, and now we're back on track and actually a little bit further ahead than we were when we were just working on our triple PD issues. Trying to think of another patient. There's another patient that Dr. Wright and I have worked with, and his big issue is he drives in traffic. There's multiple things. He talked about sitting in church and kind of sitting a little bit further back in church, and he'd look off to the right, or he'd have to look off to the left, right? And he'd look up at the minister preaching, and then he would get these waves of dizziness. Or he'd be in traffic, and it wouldn't be free-flowing traffic. If he was driving like 65 miles an hour, he was happy. It'd be when traffic would be stop and go, and he'd be still, and the other cars would be stopping and going around him. That would really mess with him visually, and that would ramp up his system. So we did a variety of different exercises. We did some of these gaze stability exercises. We've done it with different patterns. We've had Dr. Wright here who's done a lot of manual work on his neck, and we had gotten to him to a really good place with where he could tolerate being in church better. He could drive on the road better. But since we brought Dr. Wright on the case and he's been doing some more myofascial work on his neck and some other areas that have affected his proprioception, he's gotten even better. So the last time that we saw him, he was like, I'm pretty good right now. Like, I've been feeling pretty normal since the last time you guys saw me. So we're just trying to make sure that we stay on that course and we're getting as much pretty normal as possible. And that kind of brings up a final point that I had talked about actually last time in my previous presentation about POTS. And I skipped right past it. Let's talk about progress. So progress, sometimes the more blue we got, the more progress we're making. Sometimes it's like this, right? And that creates a nice upward trend. Sometimes progress is this, where we're not really getting anywhere. Oh, now all of a sudden we're getting better. But it's not that gradual incline we see. And sometimes progress is this. One day we're pretty good. The next day we have a great day. The next day, not so much. Gets a little bit tougher, and then we're back on top again. It's tough. When you're dealing with chronic issues, oftentimes, everybody wants this, or we just want it to just fill up, right? And that includes us as the doctors. But usually we get windows of time where, like, for the first time, I'm not having a migraine, right? And sometimes migraines are related to vestibular processing, right? I went this 1 month without having a migraine. I got a migraine every month. Then the next month they got 2. It's like, all right, well, we at least broke your pattern, right? That's a step in the right direction. Sometimes it's just more and more windows of time. I went 4 hours today without a headache. I've never had that before. So we need to celebrate that victory, right? And then we want more periods of time, for longer periods of time, where we have more and more progression. But there's still going to be some tough days in the meantime. It's worth talking about this because it can be a very frustrating process to where, you know, this is not always progress. Sometimes it goes up and down, but it doesn't mean that you're not making progress overall. We want to see where you just get more windows of time strung together. And it's like, hey, I went from 1 hour without a headache to 4 hours another day without a headache. And now I've had like 3 days in a row without a headache. We're making progress, right? We're making progress. So that's kind of it for everything I got. And we got a question. Awesome.
Yeah, how, that last chart, how
Yeah.
much can changes in barometric pressure affect those charts there?
Talking about this?
Yeah.
A lot. Yes. Excellent. Sorry. I should do that. So we were talking about how much can like barometric pressure play a role in here? Or just how, you know, in general, like how you're feeling your symptoms. Barometric pressure can be like a big factor. A big factor. So there's some people where it knocks them for a loop. Like I have one patient that I've been working with for a while, and one of his big struggles is he lived in North Carolina and he's moved here, and he feels like the barometric pressure and is just in a different realm compared to where he was in North Carolina. So he can have setbacks with changes in barometric pressure. And for some people that can be the case, where we get these shifts and then those can lead to bad days. Hopefully over time, you know, the more and more we're working together, the less and less barometric pressure is a factor, but it's still one of those things. It can be one of those triggers, like I talked about triggers earlier. And barometric pressure should have been on my list. But yeah, barometric pressure can definitely have a factor in this. And it's tough because it's not really something we can control or escape, right? It's not like the grocery store where you can just, you know, avoid the grocery store. So, any other questions?
Is any of that pressure, see, I have pressure
Mm-hmm.
here between my eyes.
So you're talking about with barometric pressure, or?
No, sometimes I just feel pressure right here.
Yeah, you feel pressure behind your eyes sometimes. So what can be going on there?
Very lightheaded and I feel pressure.
Yeah, you'll get very lightheaded and you'll get pressure. So what could be going on there? It's tough for me to say without examining you. You know, your doc could probably speak to that better based on what they saw with your examination. But it could be a variety of things. For some people, like they get where their neck muscles, you know, their proprioception's off, their joint and muscle input's off, and they got really tight muscles in their neck, and then we do some manual therapy on those and it can relieve the pressure. But then those muscles can get ramped up again. That could be from poor inner ear processing, right? And then it tightens the muscles again, and then it causes that head pressure. And what we need to do is we need to, in those scenarios, oftentimes work on the neck, but also work on that inner ear processing. So it's tough for me to say, like in your exact scenario, what could be causing that, but it could be like inner ear processing. It could be joint and muscle processing. It could be visual processing. But, you know, your clinician is going through and figuring out which factors are at play for you, and then getting those systems to work better. And then we should be getting less of those triggers, less of that pressure over time.
And in her case specifically, she was diagnosed with vestibular migraines.
Yeah, so yeah, it sounds like you've got vestibular migraines as well. So with vestibular migraines, that can be episodic, right? And that sometimes that goes with barometric pressure, right? And for some people, they get migraines where they just get head pain. There's some people that get abdominal migraines where their head feels fine, they don't get dizzy, they just get really bad cramping or really bad nausea, right? So it affects their abdomen as opposed to their head.
So I was surprised in your presentation where you said that the average length of time for a PPPD is 4.5 years.
Yeah. Sometimes it's longer, sometimes it's less.
I'm into 3 years.
Yeah. It doesn't mean that you're going to be, it doesn't mean if you did nothing that in like 1.5 years, like you're out of the woods. But it's more likely that that's the average amount of time that people have been dealing with it, right? And it's a little bit challenging because technically PPPD has existed as a distinct diagnosis since 2017. So that's not that long a time, you know? We're talking about not that many years.
So what happens after 4.5 years to?
Could last longer. It could last a year. Could last 5 months.
Class, the people are much better. There goes away.
Those are the scenarios. Sometimes it goes away for people. Sometimes it gets better. Sometimes it gets worse. You know, and it doesn't distinguish like everybody was doing this therapy, you know, or all these people weren't doing any therapy. It really varies from individual to individual. It's tough. They're just saying like that's the average amount of time that people suffer from this disorder. Hopefully what it means is on average after about 4.5 years, like people are doing much better. You know, you have it for a period of time and people are doing much better. But the articles also talked about, you know, some people have been dealing with this for more time, like a decade, right? What you want to do is you want to be active about it. Like you want to be proactive about it. You want to be doing things to treat it, right? That's the biggest thing. That's how it's more likely that, you know, it's not going to last 4.5 years or it's not going to last 8 years, you know, whatever amount of time we can reduce it. It's tough for me to say. It's tough for me to say.
I've been diagnosed with both PPPD and vestibular migraine.
So you got PPD and vestibular migraine. Yeah, and you're allowed to have both, unfortunately.
Mayo Clinic diagnosed me with PPPD.
Okay.
A doctor in Texas that wrote a textbook that thick that they study in medical school
Okay.
diagnosed me with vestibular migraine.
Okay.
So I feel like I'm floating around.
Yeah, and there can be some controversy between the two. There's actually research articles that talk about that because they can present as very similar. At the end of the day, what arguably matters most is not necessarily the name that we give it. It's that can we figure out what's at play and what's causing it, and can we get the things that are causing it to work better so that it reduces your symptoms, right? The frequency, the intensity, and hopefully makes them go away as much as possible. Knowing what diagnosis you have can guide us towards, hey, these areas of the brain or these areas of your nervous system could be at play with it. But arguably the most important thing is doing the examination, running the diagnostics, and just looking at what factors are at play. Your vestibular processing, your proprioception, your visual processing, your frontal lobe, your cerebellum, whatever areas or whatever parts of you that are at play with this. So it can be really confusing because it's like, well, one person thinks it's this and one person thinks it's that. And when you're dealing with, with these chronic disorders, oftentimes, yeah, there's multiple diagnoses on the table. There's multiple diagnoses on the table.
But in the end,
yeah,
the therapy approach is the same whether it's PPPD or whether it's damage from vestibular migraines or...
Yeah, in the end, the approach we're going to take in the end, we don't have a protocol for vestibular migraines, meaning we don't have someone come in and we're like, all right, they got vestibular migraines, so we do these 4 things for the vestibular migraines, or we do these 4 things.
No, those are more medication
Yeah.
controls to
Yeah.
control the blood chemistry, but the damage that's left over from years of vestibular migraines
Mm-hmm.
is the same.
Yeah, so in either case, like we figure out where the damage or the deficits are, and then we need to treat those in either case.
I had regular migraines on this side of my head for 45 years.
Yeah, and then all of a sudden the vestibular stuff set in, right?
A doctor put me on Effexor. He said this works on some people with migraines.
Mm-hmm.
Well, it worked on me. And just rarely would I have one or have the aura.
Mm-hmm.
Just occasionally. And then that was all fine, and then all of a sudden I started having all this right here.
Yeah, so it changed. So we were talking about, for the people at home, we were talking about how a medication was used, Effexor, that helped these long-standing migraines, but which is wonderful. You know, that's the beauty of medication sometimes, is that it stopped the typical migraine presentation, but then after that, then it turned into something else.
It's like it's manifested itself here instead of.
Yeah, it was more on one side of the face. Now it's more central. And it can morph like that. It can morph like that. And it's tough because there might be multiple factors at play, right, that could have made it change presentations like that. But that's why it's important to examine you and figure out what's going on as currently as we can determine, and then address the things that we can see right now, right, that are factors at play as far as why you're having those symptoms, to try and get to the root cause of it, to get your system to function better, to better process the world, and then your body reacts more appropriately to the world, where it doesn't create these pain patterns. Any other questions? No. All right, well, thank you for coming. I appreciate it. Hopefully that was helpful.
Yeah.
There's a lot of just words coming out of my mouth,
I'm
but
glad we came because.
yeah.
Just more explicit what I.
Yeah.
The guy who actually named PPPD
Hmm?
is at Mayo Clinic.
I believe that.
His team,
Yeah.
um,
I've been
So you saw the guy, which is good.
now we saw the disciples of the doc.
Okay.
Very few
Okay.
people see the doc.
That's understandable.
But they couldn't have explained it any better than you could have, so you did great.
I appreciate that. I appreciate that.
When I went to Mayo Clinic, I knew that I had PPPD. I already had all those symptoms. I knew it.
Yeah.
But they did all these tests. This is fine, that's fine. Brain, whatever they did, this is all normal. And I'm saying, but I can't walk a straight line.
Yeah.
There's something not right.
Yeah.
I'm all over the place.
So we often talk with, so the discussion was that, you know, she knew when she went to the Mayo Clinic that she had PPPD. So it wasn't necessarily a surprise for her. Maybe, did you know that word, you know? Or was it more you're like, I know how I feel. Like I already knew how I felt this way. Yeah, that's what I thought it was. Because sometimes diagnoses, like there's cervicalgia, which means you have pain in your neck. It's your cervical spine, algia meaning pain, you have pain in your neck, and it's like, thank you, I just told you I had pain in my neck, and that's the diagnosis you give me. PPPD is kind of like that too. It's like, well, I already knew that when I stand up and I move around, like I get dizzy. So it's, you know, it's not that helpful in that regard, right? So we talk about that with patients oftentimes. The biggest thing.
I still get that aura occasionally.
Yeah.
Very rarely, but I do get it occasionally.
So what we're trying to find with our patients is we want to look at these exam findings very closely. What makes this a little bit different is, I can't speak to your case because I haven't examined you, but a lot of the patients that we see, they're mostly normal, right? And it's like, hey, like all these things are working really well normally for you. These things here, they're mostly working good, but they're not great, but they should be good enough. Sometimes when some of our exam findings are decent, but not really great, that's enough to throw things off for people. So sometimes the subtleties really matter. Or sometimes we need to look at things in different contexts, right? Like my patient worked with people that did vestibular rehab, and she was doing a lot of these. But every time she turned her head, it made her nauseous. So we had to start without turning her head first, right? So she just needed a different approach, right? And that people come to see us because we look really close at the details. And an ideal scenario for us is if someone has symptoms, we find some things wrong. Because if everything looks beautiful, then we can't help you. So we want to find some things wrong. We just want a short list. We don't want a big list. So with most of our patients, we can find a short list of things to work on, and then we work on those things. And even if they look pretty good, if we can get them looking even better, if we can get those parts of your brain working even better, you're going to feel that much better. So sometimes it's in the subtleties too, and sometimes that's what's missed. So
I never get nauseated.
I'm glad to hear that. I'm glad to hear that.
Had everything else, but.
Yeah. Well, everything else is enough, right? You don't need every every symptom under the sun.
Believe me.
So I'm glad you've been spared the nausea. So, any other questions or concerns? All right. Cool. Well, thank you for coming tonight, and thank you to anybody that tuned in. and who watches this video later.